I think that one of the main themes that came through is the goal of our healthcare system is not to save money, it's to improve health. And Dr. Volp and I and all the other clinicians in the room did not go to medical school and nursing school and pharmacy school to learn how to save money. Although Stu lived up to my very almost accurate prediction that someone would show many slides about how much we're spending. But he also was so kind to show how little we're getting for our money. So I think that no one argues that there's not enough money in our healthcare system. So we are switching, trying very hard to dialogue from how much we spend to how well we spend. And when Mike and I came up with the VBID concept, it was all about this redistribution of our healthcare dollars. And the basic premise was that not all healthcare services are equal value, and those of high value services should not be hard for patients to get. And while we'll hear more about what those high-value services are, I think most clinicians and maybe many patients would know these are the things that we beg our patients to do. Immunizations, cancer screenings, treatments and medications for chronic diseases that make up the majority of spend of healthcare in the United States. But I thank Alan Weil so much for bringing up this idea of the need for integration. As most people know, the integration word is the buzzword. And as I try to beg all of you as stakeholders and policymakers on both state and the national level, I try to explain to them, while so much of the effort is going on the supply side, that being medical homes and ACOs and payment reforms like bundled payment, as an academic, I have to use a very sophisticated term when I talk about supply side. I call that peanut butter. And what we've been trying to do with VBID now for almost a decade is get people to understand there's a demand side or a patient engagement side about this discussion, which I call jelly. So sorry if you're not understanding this very sophisticated model. But you might remember that first time when you put peanut butter and jelly together that something magical actually occurs. And that is what we're really trying to do, and I think Alan's points were very well taken as they tie into Senator Daschle's, is that if we really do integrate the great work that's going on the supply side with what we're trying to do to add clinical nuance to the demand side and the patient engagement side, we could deliver more health at any level of expenditure, which is the goal of VBID. So the hypothesis that we wrote about quite nervously, Mike and I, in the beginning, was that this reallocation of healthcare resources would lead to better health, which is the goal of the clinical side, but also more efficiency to the system, which is what the economists and the finance people bring to this discussion. Two very important hypotheses. And I think the basis of our two presentations on evidence, the first question is how best do we set up these incentive systems? And we're lucky to have Kevin Volp from the University of Pennsylvania, who literally is, in my opinion, the nation's expert on designing and evaluating incentive systems for healthy behaviors in the management of chronic diseases. And the second big question is, does VBID actually work? Does it improve health? Does it add efficiency? And we're very pleased to have Teresa Gibson, Director of Outcomes Research at Thomson Reuters, who has pretty much been the leader in terms of doing evaluations of VBID programs around the country, primarily in the commercial space. Because the two questions are so different, I think unlike the other panels, I think Kevin will go, and I think he'll take a few questions from the audience on his work, and then we'll transition to Teresa for the closing part of the panel, and she'll take questions on the evidence side. With that, Kevin, I turn to you.
Thank you. Well, thank you, Mark. And I want to thank Mark and this center for really helping to get the issues we've been talking about today in the hands and minds of so many policymakers and employers around the country. I think this center deserves a lot of credit for that. The way I've thought about value-based insurance design is it's a very important effort to try to get the prices right and figure out how to line up what we're paying for health services, what we're asking patients to pay for health services, ideally what we're paying providers for health services, with the value of the services that are being obtained. But what I'm going to talk about in the next 15 minutes or so is that I think there are a lot of really important behavioral issues here which are going to have a big impact on how effective these initiatives are. And I'm going to take you through some examples of this to try to help you think about how you might do this in different ways. So let's go to the next slide. Or am I assuming that this doesn't work?
My phone's not going to help you.
Okay, your phone will not help me. Maybe this will help me. Good, okay. All right, Well, I'm a human, not an econ. And so this is where I want to start. If you think about prices, we're basically presuming that people respond to prices rationally, and I think by and large people do. But the standard neoclassical view of people as junior economists who make decision trees in their heads and calculate the expected utility of all the different things that can happen and the probabilities, and then through backwards induction figure out what should I do today, that model probably doesn't so neatly apply to most of us. And people behave in humans in various ways. They're very focused on immediate gratification. They're very loss averse. They're affected by their emotions. They have self-control problems. They tend to be overly optimistic. And so the point is that not that either of these views of the world is right. It's that they're both partly right and they're complementary. And the basic point is that people respond to prices, but there are other factors that also very much affect their decision making. This is an example of a medical plan, and this is one of many, many, many pages like this which spell out in excruciating detail in these different plans. Here's what I'm going to be subject to. And as you know, a lot of effort goes into plan design, but as you work through this, you realize it's a very complicated maze of co-payments, deductibles, co-insurance, maximum out-of-pocket, dollar limits, visit limits, allowances, flexible savings accounts, health reimbursement accounts, health savings accounts, personal benefit allowances. And so you get the picture. There's a lot to process here, and I think we're probably fooling ourselves if we think the average person really understands what they're being incented to do and what they're being disincented to do. So we need to think about, in essence, this basic issue that a lot of the plan designs are just way too complicated, and I think that makes our efforts to modify the price of services and use that as an incentive probably less effective than it otherwise would be. So let me tell you a story about two different programs, and this is from a very different realm. This is from the realm of trying to get low and moderate income families to save more in tax-protected savings plans, and as you may not be surprised, these rates of savings are quite low. So H&R Block worked with a team of academics back in 2001. They enacted something called the Savers Credit, and this seemed fairly intuitive at the time. They basically set up a federal income tax reduction of up to 50% for funds contributed to people's IRAs. So for people in the lowest income group, this is actually equivalent to a 100% match. And a lot of programs that the government runs relate to giving people deductions off their taxes. So this is a pretty standard way of doing things. They also tested a different approach using a savings match. And in essence, what they did here is they randomized clients preparing tax returns at different H&R Block offices to one of three matches for IRA contributions, either 0, which was the control group, 20%, or 50%. So note that the amount of matching here is actually a lot less, 20 or 50% as opposed to 100%. But basically what they found was that the take-up rates were actually much higher in this group that was in the match experiment. You can see the 3%, 8%, and 14% for 0, 20%, and 50% as compared to the 3% for the 100% effective match. And then the contributions were also much bigger. So you might wonder, why does this seem to contradict standard economics? Standard economics would have said 100% effective match, you're going to see by far the highest participation rates. And I think there's really two main reasons. One is on the Savers Credit, you have a benefit that's integrated with and in essence lost in a large payment, e.g. people's income taxes, and therefore it's not very salient. You also have a reduction in an amount one would otherwise have had to pay, and this is very amorphous. It's very hard for people to calculate. On the other hand, with the match, you have a benefit that's separated, it's very salient, and you feel as if you're getting a gift that you'd forego if you didn't put any money in this account. So the basic lesson here is that a dollar is not a dollar is not a dollar, and how we think about the dollars floating around in the healthcare system, whether it's through VBID or supplementary reward programs, actually matters a lot because it will have a great impact on how effective those programs are. Now, what are the implications for VBID and incentives? I think the first is that adjusting price alone is not going to achieve the desired effects to the degree we want them to. And this is true whether we're talking about copay reduction or premium adjustment. And we need to think about how we deliver these programs. Are the embedded incentives salient? Is lowering price to 0 sufficient? I don't think we're going to have colonoscopy screening rates of anything close to 100% if once colonoscopies are free. Framing of losses versus rewards, other decision errors like present bias, mental accounting. I'm going to talk about these a little more in a moment. And we need to think about the intersection between getting these prices right and acknowledging that various kinds of decision errors are very common, and we have to take these into account when we're thinking about how to incent people to do the behaviors that we would like them to do. I'm not going to go through all of these in detail, but this is just a sampling of the work that's emerged from behavioral economics, where each of these decision errors has a literature supporting it. So for example, present bias preferences. We know people are disproportionately affected by the here and now. What are the costs and benefits of the decision for me right now? And then there's a discounting of the future, which is very delayed and much more than what you might think is quote unquote rational. Now this is a really big issue when you think about a lot of behaviors we're trying to change, like smoking. Because if I'm thinking of quitting smoking, it's very obvious to me that this week is going to be an awful week. I'm going to go through nicotine withdrawal. I'm going to have to relearn all my old habits. I'm going to be miserable in all sorts of ways. And the benefits of smoking are very far off in the future. And in fact, they're so far off in the future, it's almost easy, if I heavily discount the future, to discount them to zero or close to zero. So the rational thing to do then becomes not to quit this week. And the problem is, next week, it'll be the same story, and the week after. So we have to think about incentives as a way to change some of that underlying dynamic, but that's just an example. I'll also talk a little bit about the framing and segregating of rewards. I alluded to that with the H&R Block example. I worry that we're falling into that same trap as we move towards adjusting premiums based on biometric measurements, because I think that that's not going to change behavior that much. It's probably mostly going to shift costs to higher risk people. But anyway, there's a whole series of these. In the interest of time, though, I'm not going to go through them in detail, but I think all of them have implications for how we should think about using incentive dollars to motivate behavior. Now, we know that employers are moving more and more to use incentives. The rate is increasing pretty steadily, and I think this is going to be accelerated quite a bit by a number of factors. One, of course, is increasing concern or ongoing concern about the rate of increase in healthcare costs. Another is that there's acknowledgement that employees' poor health habits are a big challenge to maintaining affordable benefit coverage. But you need to think about how do you design these programs. So this is an example of a program which I think is not that well designed, but it's very typical of the kinds of programs that are out there. Here you can get, if you complete 120 workouts in 365 days, you'll be eligible for a reimbursement of up to $150 off next year's premium. Now, that doesn't sound so bad. It seems like a reasonable thing to offer your beneficiaries. But as you start thinking about it, you realize that this approach has a lot of inherent limitations. One is that if it's a cold day in January in Ann Arbor, and I'm thinking about going to the gym today, the prospect of getting some money off my premiums next year is probably not going to motivate me. I see a lot of people nodding their heads with that. But at any rate, the second issue is we have here a single high threshold. And this is a very common design feature, but is also very problematic. The people who you'd like to get to exercise more are the people who don't exercise at all, people who go to the gym 10 times a year. And the people for whom this incentive is really in play are people who already go to the gym 100 times a year, and they think with a little more effort, I could get that $150. So you're really probably moving the needle on people who don't really need your help, and you're probably not going to really change the behavior of people who don't exercise at all. So here's an example of the kind of programs we've run which do work, but there are a number of limitations which I'll talk about momentarily. This was a study we ran among employees at General Electric where we were trying to increase smoking cessation rates. We randomized smokers to either get information about a free smoking cessation program or a package of incentives that were worth $750. If you did a program, you quit for 6 months, and then you stayed smoke-free for another 6 months. And we ran that for a year, and then we turned the program off to see what would happen in terms of sustainability. At a year, what we found was that smoking cessation rates were roughly triple in the incentive group than the control group, 14.7 versus 5.0%. That's a ratio of 2.9. 6 months later, that ratio declined to about 2.6. So you do see some relapses in everybody, but they happen at about the same rate in the incentive and control group. Based on this, GE implemented a plan for their employees in 2010, but there's an interesting side story to that, which is that they took our carrot-based program and turned it into a stick-based program where they, in essence, increased premiums for smokers, and they exempted people who in the first year did a smoking cessation program. And that's a whole nother story, which we could talk more about in terms of when people use carrots, when people use sticks. There are pros and cons. There's very little data on relative effectiveness. Carrots tend to be a lot more popular among employees, as you might imagine, and I think in essence that's why they moved in this direction, because they didn't want the non-smokers to be upset that they were rewarding smokers for something they should do anyway. But there are issues with having a lot of stick-based programs in terms of the type of climate that creates in the workplace and the sense that for some types of behaviors that may be overly punitive. Here's an example of another type of approach we did among a McKinsey client that was a medium-sized employer. And this was a so-called Dutch lottery study. And as you know, a lot of employers are struggling with trying to get employees to fill out HRAs. Without HRAs, they don't really know what people's BMIs are and whether they smoke and what their exercise habits are. So a lot of employers are using incentives. This employer was getting a completion rate of about 40% paying $25, so they wanted to do the logical thing, which is to pay $50 and try to get that rate up. And we convinced them to run this as an experiment. So the way a Dutch lottery works is basically, in this case, we divided a workforce into small groups, natural groupings of 4 to 8 people. We had a 4-week campaign where we encouraged people to do their HRAs, and each week at random, we picked one group at each work site. So you had an expected value of $25, but if you were selected, you'd actually get $100 if you personally had completed your HRA. If you hadn't completed your HRA, all the other people in your group had completed their HRAs would get $100, and you would have the feeling of being left out. And the basic idea here is it actually plays on a lottery that runs in the Netherlands, where they divide people into census groupings, and they have them split much bigger prizes. In that case, in some cases, millions of euros. And the idea is that there's a palpable sense of anticipated regret people have, where I don't want to be the only person on my street who didn't buy a lottery ticket when everyone else is going to be splitting 3 million euros. So the idea here is that you're playing on anticipated regret. It's not just about expected value. And we had an added bonus here. If more than 80% of the people in your group had completed one, you'd get $125 instead of $100. So what we found is when we went from $25 to $50, very, very small difference, about 40 to 42%. But using the same amount of money, using this Dutch lottery approach, we got to about 70%. So as you know, one of the big elements, at least from our perspective, in terms of the Affordable Care Act is Section 2705, which can increase the amount employers can use for basically outcome-based incentives for employees based on biometrics like blood pressure, LDL, smoking status, obesity, to up to 30% of premiums and potentially up to 50% with special discretion. So this is a huge, huge amount of money. And one of our concerns is that what could happen here, and the easiest way for employers to roll this out is going to be just to adjust premiums based on these approaches. And what could happen then is you just end up having heavy people paying a lot more for their insurance. A lot of this depends on how much you think people can change their behavior. But one of the points I want to leave you with is the sense that mental accounting is really important. And if you do this through premiums, and it's buried in either direct deposit or automatic withdrawal from people's bank accounts, it's going to be much less visible to them than if you can unbundle this and figure out a way to reward people more directly. We also think that it's important to think about ways to do this so that these rewards are provided in the present, because if you do it based on your next year's premiums, that again is not going to motivate people today, and there's going to be a natural tendency to procrastinate. And then, of course, today becomes tomorrow. So there are a lot of questions we don't know the answer to. We really don't know what the relative effectiveness of carrots and sticks is. We don't know that much about incentives and the optimal duration, design, magnitude. There's a lot of fundamental questions we don't know. We don't know whether adjusting premiums by 20% 30%. How much is that actually going to change people's behavior? That's really an open question. There's very, very little data about that, even though we're about to embark on what could be a massive social experiment in that area. We also don't know what context makes most sense. It's very clear that in looking at the incentive literature that it's much easier to succeed with one-time events. If you're trying to get a preventative screening done, if you use an incentive, that can increase the rates, and there's no concern about sustainability. It is clear that it also is much more effective for smoking. I think a lot of that has to do with changes in the social environment, the built environment, what's happened with excise taxes over time. So if you're trying to be an ex-smoker, that's much easier than if you're trying to lose weight and keep that off. But lots of questions there about what are the right places to use incentives, how much should we use incentives, how do we best leverage social influences. A lot of work is being done on this, but there are a lot of outstanding questions. And I think the really big question is how much this is going to influence the health of beneficiaries as opposed to be used to shift costs to higher risk people. A lot of us are really concerned about that. I think there are great opportunities here given the greater acknowledgement of the role of health habits and the interest in using incentives to improve health behavior to actually improve health outcomes. But I think we need to tread very carefully in how we think about rolling out these programs. So in summary, I think getting prices right through VBID is only part of the battle. It's absolutely an essential part of the battle, and there's a lot of really important work to be done on that front, particularly in reducing, well, not only in reducing barriers to high-value services, but increasing cost-sharing barriers to low-value services. I think that's really an area we need to push really hard on, ideally both on the patient side and the provider side. But ideally, we should also be trying to think about how do we take into account these common decision errors, the fact that people are very myopic, the fact people have a lot of inertia, there are these mental accounting issues, there's loss versus gain framing. How do we use that to make dollar for dollar these interventions more effective? And I also think it's really important to think about what are the social and environmental factors that we can try to leverage to make these programs have more self-sustainability. One of the other key points here, and it may sound to you like I'm saying we don't know very much about any of this, and that probably overstates it a bit, but I think there's a lot that we know, but there's even more that we don't know. And one of the key things here is as employers and payers roll out new programs, I think it's really essential that we try to learn as much as we can from what we're doing, because there's a lot of, I guess I'll put experimentation in quotes, but there's a lot of experimentation that's going on, a lot of innovative approaches that are being tested, but often they're not being rolled out in such a way that we can meaningfully evaluate them, so we don't really know what the impacts are. And I think that's where in the coming years, particularly as we move towards 2014, where we need to really try to make a concerted effort to all work together to learn as much as we can from the innovations that are happening. Thank you.
So Kevin will take his questions now. If people would like to come to the microphones, I will tell you that that was very compelling, Kevin. And as a fellow academic, I like to tell audiences like this, I published and I still perished. And I want to ask you the question that now that you have a different audience than reads your New England Journal papers and your other academic papers, you see that there is this substantial lag behind what you think may be the right thing to do in this area as opposed to what's happening in the real world. And given that we've had similar struggles trying to change benefit design, I'm wondering if you could speak experientially and inspire this audience to actually move forward faster with what your evidence would suggest.
Yeah. Well, it's actually a really interesting question, because in some ways what's happening is racing way ahead of us as opposed to being behind us. And I think it's a big challenge, because when you look at whether you're looking at value-based insurance design or what's happening in terms of wellness programs and incentives, it's very clear that there's enormous interest and a lot of employers are racing ahead and implementing programs. And I feel that there's a lot of best practices type approaches that are being taken where it seems intuitively obvious that we should do X, Y, and Z. But when you look at how much data there is actually supporting X, Y, and Z, it's often very scanty. So what I'd encourage people to do is really take a hard look. I think there's a lot of of the status quo bias in all of us, that we don't apply the same scrutiny to what we're doing and what we're spending money on as we do to the new initiatives we're considering. And I think what we need to do, as Mark alluded to earlier, in essence, is really take a hard look at how are we spending money now, and what are the effects of that, what are the incentive effects on behavior, how can we think about reusing some of those precious dollars more effectively? Because I think that's really what we need to move towards.
Thanks. Please identify yourself.
Great. My name is Martin Zagari. I'm from Amgen. My question concerns actually insurance and then the value of the components of what we're consuming. So I really enjoyed your talk because I think that it's ultimately the sum total of individual actions that is also going to get us out of the crisis that we're looking at 10, 20 years out. My family and I are relatively healthy, and I loved your slide showing an average insurance program. It's become bewildering. My question is, part of the unwritten benefit design in all of these is what one pays for the services on the open market. I'm struck by an event a few years back where we had a minor surgical procedure that was needed in our family, and we ended up, my insurance company ended up paying about $5,000, and yet the bill was $60,000. And so pricing of healthcare services outside of an insurance plan seems just totally irrational. So how do we, if the unit of consumption is insurance, but we're also wanting people to pay more outside of their insurance plan, we're actually passing costs on. There's a trend now, as you probably are well aware, towards very high deductible health insurance plans. How can you actually make behavior totally rational if the underlying value and prices of the services seems totally irrational?
I think it's a really important question, and I'm not sure I have a clear answer to it, but I'll try. So I think part of what we need to do is to just simplify, at least from the patient and user perspective. So I don't think patients can really make meaningful decisions based on whether this procedure is $60,000 or $50,000, and that's what's costing my plan. I think we need to think about a grossly simplified view of the world where, for example, we could put all goods and services into a high-value bucket, a low-value bucket, and somewhere in between. And ideally, a lot of things are on these in the high and low, otherwise everything's in the middle. And then we think about saying, well, why are we having any cost sharing for the high-value services? We should have much higher cost sharing for the low-value services. And I think from the end-user standpoint, if we can just distill things down into, let's say, 3 buckets, then I think people could make decisions and really think about, well, there's 3 different treatments I could have for this problem, and one of them is in the high-value bucket and 2 of them are in the low-value bucket. And then, yes, you could pick the low-value one, but you're going to pay a lot more for it. I think if we can simplify things in that kind of way, that could work. But it's actually very hard categorizing those services, which is one of our challenges.
We'll hear about how some organizations have actually made those tough decisions in the first panel after lunch. Please.
Hello, my name is Kelly Shanahan Marshall. I'm with an organization called Engaged Public. We're based out of Denver, Colorado. And thank you so much for your presentation today. We are working on a VBID implementation, a pilot in Southern Colorado, and we're adding in a component of shared decision making and the use of patient decision aids. And to my knowledge, there hasn't been a whole lot of work or evaluation on using financial incentives to incent shared decision making. And I wondered if you might comment on that and if the field of behavioral economics has done any studying on that.
There are some people who are working on it, but I don't know of anything that's been published either. I think the basic issue that there are, for example, a lot of surgical procedures where it isn't clear what the best treatment alternative is, where shared decision-making could play a role. That if we could get people, for example, to consider doing second opinions routinely, we might find that people actually would choose on their own not to have this knee surgery. So I definitely think there's a role for that. Part of what we need to do is figuring out how to not just offer it to people, but to get them to uptake use of this at high rates. Because if it's an opt-in kind of model, you might have 5–10% of people use it, and that's obviously not going to have a big impact on either costs or outcomes.
We're looking at like a gift card, $50 gift card type model that they would get right away for using the patient decision aid and engaging in that shared decision making.
Yeah, you're not alone in some of the more innovative plans that have not been evaluated but are implemented in pilot are using that exact tool just to get people to go through the process and do nothing at the end once they come through. Matt, please.
Good morning, Matt Davis. Thanks for your comments. I'm a primary care doctor and a health policy researcher here at U of M. And I wanted to ask you to comment a bit more on an element of carrots and sticks that I experience in primary care, which is that patients get monetary rewards based on my actions. And in that way, I am linked to them and they are to me, sometimes through getting lab tests done in appropriate manners, sometimes with timely completion of forms, such as last week when I got a message that my diabetic patient would get $50 today if I faxed in this form that was due. Who am I to deny my patient $50, right? So I put aside the other paperwork I had and put that first for him, right? But so where do we go and what evidence do we have about these linked incentives where the physicians are part of how the patients are trying to respond?
Yeah, great question. This is just starting to be rolled out to greater degrees, so I don't think we have any evidence on how effective those approaches are. I think a lot of people have wondered for a while whether it makes sense to be incenting providers to improve blood sugar control when a lot of that is really under the patient's control more than the provider. So there's definitely a lot of interest in thinking about how do you view the provider and patient as a team. Do you have incentive for patients, incentives for providers, some hybrid? And nobody really knows. I think there's starting to be some interesting innovation in that space, but nobody has any data yet, as far as I know.
Last two quick questions and quick answers, please.
Hi, I'm Kathleen Callahan with Buck Consultants. This is more of something else to comment on versus a question. You were talking about how incentives are often buried, and I'm wondering if we could take some ideas from the consumer marketplace where employees or healthcare users might have somewhat of a rewards card that earns them points as they fill prescriptions for needed medications or get preventive care. And if you think that would be effective or if that would just complicate matters.
Well, it's an interesting question. You know, part of what I didn't talk about is that I think it's very important for us to get the prices right because there are incentives embedded in whatever we do. I mean, even if we didn't have VBID and we weren't trying to do anything, that there's an incentive built into that. But that said, as we move to a world where there are more and more of these incentives, I have mixed feelings about that because I think a lot of what motivates people is not financial incentives. It's how they feel about themselves, social status, peer recognition. So I would say if you wanted to design a reward program like that, I'd think about making it maybe more about status levels like the airlines and maybe less about sort of direct point translation into dollars, because I suspect that might be more effective.
Peggy.
So I just want to make a plea, which is, can you do some focus groups? I know that's not what you do, but work with some marketing people, because I think, we're doing all these things now that are going to change what people encounter in healthcare, and I think we need to understand how they're receiving this. I love your presentation. I think it's fabulous, and I just want us to make sure that we do this in a way that public gets it, that they will be cost sharing, that we're trying to do it in a way that allows them to optimize their health. And I I mean, you're in such a pivotal and important position. I just want to make a plea. Thanks.
Oh, well, thanks for the thought. I'd love to talk to you more about that.
Yeah, and Peggy, our center's engaging in qualitative research around people understanding VBID and adopting VBID. It's obviously a critical importance of moving this forward. So thank you, Kevin. With that, I'll invite Teresa to the stage.
And let me apologize. I have to be back in Philadelphia, so I'm going to skip out momentarily.
Waiting for my slides here.
We're all capitated. We could wait.
Okay, evidence. So this is what I'm going to go through today. First, background on evidence. then look at some criteria for evaluating effects. We'll look through some evidence on VBID from some of the programs that have come out already. Delve into 2 studies, one observational and one randomized that just came out. I'll talk about some evidence that I have in progress and that I've heard about also, and then desirable evidence, evidence that I'd like to see. So here's a piece of evidence. So related to Dr. Fendrick, actually, and I do know something about the topic here today about VBID, but I felt unable to turn Mark down. And this is why we were on a flight from Atlanta to Detroit, not traveling together. And I knew that he was in the first row of coach, and a passenger in the back was in distress. And they were talking about calling for a doctor, so I told them that Mark was a doctor. And I hid. He kind of gave me a look as he walked past me, like, what is this? So he did help the passenger, he did render aid, and we did land very early. So that was good, 25 minutes early, and I think the gentleman was fine. So next time I'll let you volunteer. And so let's move on here. So the first bit of evidence is the RAND health insurance experiment. It's always good to go back to this because this has been the gold standard, is the gold standard. The design is 6 cities and fee-for-service plans. And one thing why I wanted to point this out was that the amount of support for higher coinsurance levels. So the VBID studies that we're seeing are in the lower range here, in the free 25%. The RAND health insurance experiment really went up to 95% cost sharing, and then there was a maximum dollar expenditure, so it was capped. And folks were made whole afterward. But just to think about that when we're starting to evaluate evidence and to produce evidence. The individuals participating in it had no selection of health plan. They were assigned to a health plan using randomization. And the findings, I'll just quote here, the data from the HIE clearly show that the use of medical services responds to changes in the amount paid out of pocket. So that established that piece of evidence for us. So that was in essentially across a variety of cost-sharing levels. So how do we, so there's 2 pieces of evidence I think that we need to continue to produce. The first piece is how do we know an intervention works? So this is when we randomize, isolate, ensure reliability of evidence. And what are the effects of this specific intervention? So what are the effects of VBID? So those types of studies are designed in a specific way to answer that question. Then, how does an intervention perform in a real-world setting? That's the second piece of evidence, and that's a lot of what we're seeing out of these employer-based plans. This is important, too, because it can, in more of a laboratory setting, work in a certain way, and then in a real-world setting, work in a second way. We need both of these. We don't just need one of these. So when we evaluate the evidence, we need to start looking at these studies and provide some criteria for looking at the evidence. So we look at the strength and intensity of the intervention. So for VBID, did it include a reduction in copays for brand name medications, or did it include generic medications, or both? Because we'll get different effects. What's the amount of reduction in cost sharing? And then what is the percentage reduction in cost sharing? And how did you get into the VBID program? So was it a disease-specific program, a medication-specific program, or were there incentives for engagement? Is there a comparison group? We really need to include comparison groups in all of these interventions to look at what's going on as a contemporaneous trend. Was the comparison group internal, so were they subject to the same conditions as those receiving the intervention, or was it external? And how did you get into the intervention group versus the comparison group? Was there randomization? Was there assignment? Were there different sites? So the closer we can get to randomization, we can take out of some of the biases that might be introduced in assignment. And then the length of time studied. We're starting to see with VBID that the effects can change and can grow over time. So the size of the groups, bigger is better, obviously. And the outcomes and measures, we're starting to see a variety of these too. The methods of comparison, multivariate methods, or if you use randomization, you can use different methods. And then one interesting thing that's been used in a few studies are falsification tests. And there's one study by Massachusetts that came out about a year ago that analyzed the effects of the VBID program that was applied to 4 medication classes and 2 additional classes that weren't subject to the VBID. And so when he saw no change in those, that actually validated the effects in the classes that were included in the VBID. So this is something, a technique that can be also used. So the design elements are important when we look at evidence, but also the context. You know, which VBID programs are in place? Is it just one condition or is it many? What are other programs in effect? Because we're starting to see this layering of programs together, which is kind of interesting. And then where is an individual coming from? What program were they in before they received a reduction? And so the context is important, and also the design elements. So I've laid out 9 interventions. We're not going to go through this, and especially right before lunch. And taken these and put the pre-cost sharing, post-cost sharing, the target of the intervention, and then the comparison group. And we need to start laying these things out for the evidence as it's produced and as a whole. And I'll go to one that I'm familiar with here. So the first one here is an analysis of a diabetes medication value-based insurance design program. And the pre-cost sharing was a 10%, 25%, 20%, 35% in the 3 medication tiers, and the post is 10%. So we see a variety, as I flip through, we see a variety of interventions. Not everyone is using the same intervention. Not everyone is lowering copays for brand name and generic in the same manner. So we have to take into consideration some of these are a lot more aggressive than other interventions, and put that in context because it'll probably produce a little bit of a different result. And so the target was diabetes medications. And then the interesting thing about this is this firm was able to assign different worksite groups into the VBID, and others were not subject to the VBID. So you had a lot of the same conditions, same workforce in effect to make a comparison. And they were large enough that we could do a propensity score matched comparison. I'll go through this in a little bit more detail later. And then we'll start to tally up the adherence effects and then outcomes and costs and things like that as those become available across studies. So I just took the adherence effects here in these 9 studies and laid out the effects. So which medication classes were affected in a positive way, which were neutral, what size effect was going on, and we can start to assemble that to provide additional evidence for future programs. Okay. And so I'm going to go just quickly into a program that I evaluated. This was published in Health Affairs last January, and I just described the program. This was funded by Merck, and I know some of the Merck folks are here. And so we looked at a VBID program in patients with diabetes medications, and this is where we had the internal comparison within the same firm. And we did one-to-one propensity score matching to provide a comparison. So we tried to have some really rigorous design elements within a real-world setting. And one thing we did, which doesn't come out in the publication as much, although if you look in the online attachments, you'll see this. We actually did a comparison to market scan for the disease management only group, and just to provide sort of a leveling of where they compared to national norm. The length of time studied was 3 years. The size of the groups, one was larger, 1,800 had VBID, and they were also enrolled in disease management, and another had no disease management. It was a smaller group. Outcomes were adherence and utilization, receipt of guidelines, and spending. And methods of comparison, we used multivariate methods. So here are the results from the adherence. So in orange, we have the VBID plus DM program, plus disease management. In gray, we have the no VBID, but they had disease management. And then blue is the effect size. So as we can see, all anti-diabetic medications, year 1, year 2, year 3, we see an increasing effect over time. So the results, to summarize, are the combination of VBID plus disease management is more powerful than disease management alone, so you add the VBID on, and prescription drug utilization and adherence to guidelines. And then effects on those who opted out of disease management weren't as strong for those who also had VBID, but it was a smaller group. Now the spending results, I just give directional arrows, and the most interesting is probably all-cause in this, well, actually they're both interesting, but for all-cause, we see an increase in prescription drug spending, which you would expect with a lowering of cost sharing. Medical spending was unchanged and in relation to the comparison group, and then the total was also not, was unaffected. And then diabetes, we saw a lowering of medical spending. There was a little bit different effect there, so we saw more of an offset. So, and then spending effects in the VBID group without disease management were, there were no different. Now, moving on to Chowdhury's work that just came out on Monday, if you haven't seen it. I'm going to go through a similar summary of that. And this is the free trial that came out. And so going through the intensity of the intervention, they went from their existing plan in Aetna to a $0 copayment for statins, beta blockers, and ACE/ARB. And they targeted patients who had been hospitalized for acute myocardial infarction, and I'm not a clinician. And then they had a comparison group who was not subject to the copay lowering. So, and the interesting thing about how they got their intervention group and comparison group was by the plan sponsors, the employers, the unions, whoever was providing benefits, signed up in advance to be part of this intervention and randomized to one of these groups. And then as patients had this condition, then they were enrolled into the study and their copays were lowered. So the length of time studied was at least a year, but I think it went up to 3 years. Size of the groups, around 3,000 in each group for full coverage and for usual coverage. And the plan sponsors are the different groups, the different employers. And outcomes were medication, clinical, and spending. They had a number of clinical outcomes that we'll go through. So for adherence, they saw increases in all categories for the percent of days covered and percent fully adherent to the medication classes. And then the clinical outcomes, the primary outcome was the first vascular event or revascularization, and there was no change in that, so that was their primary endpoint. But then the secondary endpoints, many of those were lower in the intervention group with lower cost sharing. So major vascular events and total major vascular events or revascularization. And then effects on health spending. Patients saw lower health spending in terms of prescription drug, medical, and total. And then total spending, which is the health plan plus the employee, the patient, and an increase in prescription drug spending, and then no change in medical spending. No, overall, when you add the two together, no change. So some of the evidence in progress, I'm actually working on an evaluation of an evidence incentive-based wellness program, which talks about pulling together a lot of things that Kevin spoke about with VBID. So this program, I'll just talk through the design of it, and it started at the beginning of the year, uses biometric screenings and counseling to interpret these results. So they've had many of the employees come in and get an actual biometric screening and then have had clinician counseling afterward. They fill out a health risk appraisal. They use an incentive platform to put in health goals and commitments and receive gift cards and other things in return. And then there's a VBID component for patients with certain conditions. So they actually receive copay lowering for prescription drugs, supplies, and office visits. So this will be a neat one to see what comes out of this. So we're seeing this layering, though. As I talk to a lot of employers, through Thomson Reuters, we're also seeing that they're putting in a combination of approaches. So desirable evidence, these are things I'd like to see more work on. And so the role of office visit cost sharing in all of this. I mean, this is something we've been talking about, and like to see how much of a barrier that really is to other types of care. You have to go see your doctor in order to get a lab test. You have to go see your doctor in order to get a prescription. So bringing that sort of onto the table and understanding what role that plays. Branded generic medications, some of the literature makes this strict assumption that branded generic medications are always substitutes for each other. And from what I've seen, I published a book chapter about a year ago on this, and the evidence is really mixed. It depends on what class of medication it is, how they're prescribed, and so understanding more about that would help. Cost sharing in children, there really isn't a lot. A lot of the studies start at 18. Cost sharing in productivity, how much this affects not only medical spending, but indirect costs like productivity. And cost sharing and mortality. Now, just specific to prescription drugs here, there was only 2 studies that I know of that relate prescription drug cost sharing to mortality. And it's such an important outcome, I think we need to know a little bit more about it. So, and both studies looked at AMI patients, which is interesting. Pelosi saw no effect when copayments were actually increased after an AMI. And then Chowdhury, just with what came out on Monday, saw a lower mortality rate for from cardiovascular causes for the intervention group. So that was a positive effect. And that one, I think, should be emphasized. Optimal health insurance, and there's a paper out there by Rich Hirth and Mike Chernew and Bill Encinosa that's very interesting on optimal health insurance and sort of balancing that and patient preferences and for different treatments, with VBID. Maybe there are some ways to marry that. More randomization would be good, and then looking at these effects of combining incentives, programmatic elements, and other engagement tools that patients are being asked to use. So that's fine.
So as people come to the microphone, I'll tell you that with many champions of VBID in the room who knew VBID before it was even called VBID, although the idea seemed to make a lot of sense, there were a lot of people moving their feet slowly because the evidence wasn't there that actually people were responsive to price and that there were some medical offsets down the road. But Teresa, I know you and I have been put in tough positions because people ask us, because of the healthcare cost constraints, that VBID can't only do what we think it should do, which is provide more health at the exact same amount of spending, which I think your evidence shows, but that VBID actually has to save money, although there's nothing else in the healthcare system that does that. And one of the areas we've talked a lot about, and we've actually published in a National Pharmaceutical Council white paper that's free on our website, that we have really systematically undervalued our healthcare investments because we have not measured this productivity issue that you raise, and there's a whole separate literature that we've not really merged with that would suggest that the offsets to an employer in terms of non-medical spend may be greater than the medical spend. I know that you're examining this in very early stages, but what are your hunches in terms of how much more can the return on investment be to a copay lowering program for high-value services than just the medical offsets that you looked at?
Well, I think it's going to depend on the disease, and we're working on some studies in this area, but it's tracking from cost-sharing changes to adherence to changes in productivity has been done just a little bit in the literature and sizing that, but also just the direct effect of cost-sharing on productivity outcomes like absenteeism and short-term disability, and then also presenteeism. So it could be large in terms of savings, and that would be additive upon what we've already seen.
Right, thanks. Well, I guess this is the comment that's holding people to lunch. I just want to ask you, because if we segue after lunch into the implementation section, And you know I've lost a lot of energy and maybe a lot of hair trying to convince people to select a plan that could provide you first class for the price of coach. What do you see before we hear the champions who've been able to see VBID put in place in their various organizations after lunch? What would you describe as the major barriers that the employers you work with when you present these data about moving this forward?
I think they want to see cost savings. I think they explicitly state that. And also just, they don't know which conditions to pick. That's the other thing. So knowing more about which conditions are most price elastic and respond to cost sharing would be good too, to have more of a menu for them to choose from.
So we need more experiments for Teresa to evaluate them. With that, we'll close this panel. Lunch is just right around the black barrier. Enjoy your lunch, and we'll return for the implementation section right afterwards. Thank you, Teresa.